Well, thank you very much, Dr. Merson, for that very kind invitation. It's a real privilege and honour to kick off Global Health Week here. I agreed to come to Duke on one condition, and that was that someone took me for some North Carolina barbecue. So I already started a Twitter war yesterday on arriving where I sort of posed a question that is the pit going to be better than my favourite place in San Francisco, Memphis Minis, which does very good brisket. I know we have one San Franciscan in the audience, and I have to be careful because Memphis Minis went on to follow me on Twitter. So the barbecue last night at the pit was amazing. I'm probably going to start another war because I think the sauce from the west, North Carolina, was a little bit slightly more preferable, the Lexington style with the tomatoes, to the other Eastern vinegar-based, but, you know, maybe I'm wrong. Just a few other quick thank yous to the folks who took me out for dinner, Erin Escobar, Mike Hagland, and the two T's, Tu and Tony's wonderful daughter, and to Agata and Julie for all the logistics, the flights and hotels. As Dr. Merson said, 20 years ago, the World Bank published something truly explosive. Probably the most controversial report in the history of global health, certainly one of the most influential. You heard how it inspired Bill Gates to give away his billions. I was a medical student at the time. I do vaguely remember something about it. I remember something about DALYs, right, the disability adjusted life years, and thinking, well, that sounds a bit weird, you know, putting a value on a life year. And as Dr. Merson said, it was revolutionary partly because it was targeted at finance ministers, not health ministers, and partly because it showed that investing in health wasn't a drain on the economy, but instead was an investment in well-being and economic posterity. And it also laid out a kind of roadmap for investing in the most highly cost-effective interventions for the highest burden diseases. So prompted by the 20-year anniversary of WGR 1993, a group of 25 core commissioners came together, partly to look back at the 1993 report and reflect on how the world has changed, but more importantly, to look forward to the next generation, to ask ourselves, where should we be investing in health to make the largest gains? And one of the things that I'm going to talk about over the next 30, 40 minutes is a roadmap towards what we're calling a grand convergence in global health. This notion that the avertible deaths for infections, maternal and child health conditions, they can fall to universally low levels within our lifetime. So clearly we've come an amazingly long way from 20 years ago. I mean, the progress is stunning. Some of that is for economic reasons, and some of that is for investment in the health sector reasons. Many of the low-income countries from 2 decades ago are now middle-income countries, as you can see in this slide. When the Commission came together to think about the next 20 years, we saw that there were 3 big challenges across 3 health domains. First is the unfinished agenda of avertible infections, maternal and child conditions, mostly in low and middle-income countries. And don't forget, most poor people are now in middle-income countries. Most poor people are not in low-income countries. So if we're going to tackle this unfinished agenda, we have to focus on the high mortality regions, often rural, of the middle-income world. The second is an emerging agenda of non-communicable diseases and injuries. Age-adjusted rates of many non-communicable diseases, like cardiovascular disease, are now higher in low-income settings. And a cost agenda. We know that about 150 million people are impoverished every year around the world because of medical expenses, and we know that costs are escalating. Our report has 4 major messages, and I'm going to take each of these in turn. The first is that a grand convergence is achievable in our lifetime. The second is that we have almost certainly undervalued the returns from investing in health. They are enormous. The third is that on non-communicable diseases, there is an extraordinarily powerful lever out there fiscal policies, by which I mean taxes, subsidies, that we are underusing and that could really have a dramatic impact. And lastly, Dr. Merson mentioned universal health coverage, UHC. It's the buzziest buzz term in global health right now. We took a very selective, very targeted view of what UHC meant to us in the report, which I look forward to sharing with you. And that is that we lay out what we call progressive universalist paths, or pro-poor pathways to UHC, where you begin with interventions that will mostly, initially, favour the poor. A grand convergence, we argued, is achievable in our lifetimes. When you look back at the broad sweep of history, there was a time when the planet was converged. We were all universally sick, poor, miserable, we died young, rates of maternal deaths were high, rates of child deaths were high, brutish, nasty, short lives universally. That was the human condition. And then something curious happened 200 or 300 years ago, where the rich world started to see these very dramatic declines. You can see Sweden here in their under 5 mortality rate. But the poor world was left behind, a grand divergence in global health. But then in the last few decades, a group of very high-performing middle-income countries like China, you can see here, Chile, Costa Rica, started to see declines in their under 5 mortality rate from a very focused, almost ruthless attention to their health sector. And they started to converge on the rich world. You can see China converging on Sweden now. And we are on the cusp of something truly historic. If you step back and think about it, it really gives you goosebumps. We, this generation, our generation, we have the financial and the ever-improving technical ability to see all countries converge, a grand convergence in health within our lifetime. Our generation is unique in being able to make it happen, and it's a once in human history opportunity, because once the world has converged in this way, hopefully it will never diverge again. And I'm going to talk about the costs in a minute of getting there. It's about $70 billion. That's the incremental cost each year over and above what we're currently spending on health. But it's not sort of high-risk venture capitalist stuff where you just don't know what's going to happen with your money. We know that countries that aggressively scale up health interventions and are very focused on their health sector can achieve very rapid reductions in their under 5 mortality. This is Rwanda, that recently experienced the fastest decline in child mortality in history. And there are other countries, Ecuador, Egypt, Indonesia, Bangladesh. These are countries that all saw declines of at least 40% in their child mortality rate over just a decade. We set out convergence targets in our report that are easily remembered as 1684. These are our convergence targets from our analysis, and I'll talk about how we did the analysis in a minute. That's an under 5 mortality rate of 16 per 1,000 live births, and then AIDS and TB death rates of 8 and 4 per 100,000 population. That's roughly where, on child, the US and UK were in the 1980s. And you can see from this table that getting down to those low levels represent massive reductions. So if you take, just for example, the under 5 mortality rate in today's low-income countries, it's about 100, 104. Reaching those targets would represent very rapid and aggressive declines. So what countries are we talking about when we're talking about convergence? Well, we started with a very diverse group of high-performing middle-income countries that really do show us the way. They used to be poor. They were low or lower middle-income countries in the early 1990s. They had high mortality rates from avertible conditions. And they were very focused on health sector improvements. They are obviously a very diverse group politically, sociologically, and they were able to bring down their maternal and child death rates despite some pretty major challenges, political challenges, geographic challenges, natural disasters, and so on. And our modelling, our research shows that nearly all low and lower middle income countries could reach that kind of health status by 2035. Hence our report's title, Global Health 2035. So when I talk about these targets, 1684, they are where today's high-performing middle-income countries are on child AIDS and TB. I'm not going to go into huge detail on the modelling, because you'll probably fall asleep, but I did want to give you the overarching flavour of the approach. It combines a kind of bottom-up analysis and a top-down analysis. For the bottom-up analysis, we used a tool that's called the One Health tool. It's a country-based model. You pick a country, you pick a set of conditions, interventions against those conditions, and you estimate what kind of coverage levels you think are possible by a particular year. And the model estimates the lives that would be saved, the requirements for scaling up those interventions in terms of health systems, resources, and the costs of doing so. And we used that tool to look at HIV, malaria, reproductive, maternal, newborn, and child health. For each of these interventions, we also looked at the service delivery costs, the time of health professionals, the time of clinic buildings. There are some other conditions that are not dealt with well by this model. TB, neglected tropical diseases, health systems strengthening more broadly, not the service delivery bit, but systems strengthening more broadly. And also the impact and cost of new tools. And we use top-down approaches, global analyses for those additional diseases. The R&D part is important. We cannot converge, the world cannot converge with today's tools, right? Luckily, technology is never static. There will be new tools within the next 20 years. The pipeline is relatively healthy. And work by Dean Jameson and Stefan Vergey and others has shown that countries that very aggressively adopt new tools when they come online, they see an additional 2% per year decline in their under 5 mortality rate, which we factored into our modelling. And just to flag, Dr. Merson already mentioned, it's true there are 25 authors, but if you go to the back of the report, you'll see this is literally the truth, the longest acknowledgements list in the history of medical journals that spans 3 pages of hundreds and hundreds of folks, many at the UN agencies that helped us with this modelling. I'm going to summarise the key results. We found that achieving a grand convergence in health by 2035 would avert 10 million deaths a year, year on year, from 2035 onwards. The cost, as I mentioned, would be about $70 billion, incremental, over and above current spending, which is about 25 billion in low and 45 billion in lower middle income countries. The proportion of those costs that would be devoted to strengthening the system, not surprisingly, a higher proportion in low-income countries, 60 to 70%, whereas in lower middle-income countries, most of the costs are so-called programmatic costs, right? The interventions, the vaccines, the drugs, and so on. And we found that in low-income countries, you could close the gap between the rich and the poor on these avertible conditions. You could only get 2/3 of the way to closing that gap with the existing tools. Whereas in middle-income countries, you could get about 4/5 of the way. But in both cases, you cannot entirely close that gap. You cannot converge without new tools. So, $70 billion, right? Sounds like a lot. Perhaps. But what we also found was that the returns on that investment were enormous. And one of the things that I think we did that was somewhat innovative in the report is to go beyond GDP in thinking about the returns from investing in health. It's a field that I'm not an economist and I had to kind of get my head around, but we argue in the report that GDP alone isn't capturing the full value to a country of investing in health. GDP clearly tells you something, right? It tells you something about the instrumental value of better health, the way in which better health improves productivity. That you can capture in the GDP. But what it doesn't capture is the intrinsic value of being alive for longer. And that's what we try to do in this report. And as I said, I'm not an economist. It took me a little while to sort of conceptualize this. And I didn't really get it until I read a brilliant paper by David Bloom and his colleagues, where he tells a story, and I think I get it from this story. And that is, take two countries, country A, country B. They are similar size, similar population, and their GDP per capita is absolutely identical. But in country B, people are living 10 years longer. If you only look at GDP per capita, you are clearly failing to capture something valuable about country B. Clearly, if people are living a decade longer in country B, there is some value to that that is not being captured by GDP. And that's what we try to capture in this report in thinking about the returns to investing in health. The economic value of reduced mortality or increased life expectancy. And that is captured in the report in this notion of full income, where the change in a country's full income over a time period X is the GDP growth, income growth, as captured in the national income accounts, and the value of reduced mortality or increased life expectancy. You can value that. There are studies, there are amazing studies actually, that they're sort of like willingness to pay studies, where you can ask people, how much do you think, an extra year of life is worth? It's actually a little bit more indirect than that. What it is actually asking them is, how much more money would you want to earn to take a higher risk job? And then you can infer the value of a life year. When you use that approach, you find that for every dollar that you invest in achieving a grand convergence over the time period 2015 to 2035 would return you $9 to $20. And as Larry Summers likes to say, he can think of no investment on the planet, in any world, in any field, that gives you that kind of a return. So we think there's an incredibly compelling economic case for investing in health. So where is this $70 billion of additional money going to come from? Here's something that I found fascinating. We asked the IMF to run some numbers for us. The IMF was part of our commission. And they estimate that the lower middle income world, low and lower middle income countries, are predicted to add $10 trillion per year in their GDP from now to 2035. That's about $1 trillion in low income and $9 trillion in lower middle income countries. And if you go back to me saying what the cost was, $70 billion per year, what we are arguing is that if low and middle income countries were to commit to spending about 1% of that additional GDP, they could largely fund the grand convergence domestically. It's a powerful message. It does, of course, require a commitment and advanced planning to make that happen. We also lay out ways in which these countries could mobilize additional domestic resources, taxing tobacco, alcohol, sugar, the extractive industries, good for health, raises revenue. There are ways in which money could be reallocated from other sectors. One that we focus on in the report is fossil fuel subsidies. It's amazing, stunning, incredible how much countries are spending to subsidize fossil fuels. There are some countries, India, Pakistan, Indonesia are some examples, there are many more. They spend more to subsidize fossil fuels than they do on health and education combined. And lastly, and crucially, there is a strong call on this paper for the international community not to retreat from global health, but to step up its commitments. The nature of that assistance is likely to change. As I mentioned, today's poor countries are getting richer. We imagine a world in which international development assistance evolves away from direct cash transfers and more towards a shared global public goods agenda. But nevertheless, there's going to be plenty of countries that are going to rely on international assistance for years to come, particularly fragile states. In fact, on international collective action, perhaps the most important message in our paper is that we think the best way for the international community to support the convergence agenda is to double down on its efforts on research and development to find tomorrow's health technologies. Right? We are spending about $3 billion a year on R&D for conditions that disproportionately affect low and middle income countries. That's kind of pathetic. It's about 1 to 3% of total health R&D, even though the burden of these conditions worldwide is enormous. So we in the report instantly call for a doubling of that. And we think middle income countries should contribute about half of that additional $3 billion a year. We lay out some of the examples of these tools that we think could have a particularly large impact or a game-changing impact, and we estimate when these are potentially likely to come online. So, for example, there's a great deal of interest and excitement in developing a so-called single encounter treatment for malaria. Vivax and falciparum, the two main kinds. Wouldn't it be incredible if instead of having to take a course, you see a patient, you give them one dose of one drug that cures both, boom, that could be a game changer. An HIV vaccine, obviously, an effective malaria or TB vaccine, game changers. In case you're wondering where we are on maternal mortality ratio, that's where our modelling estimates that low-income countries will be at about 100, middle-income countries at about 64 per 100,000 live births. You may have been following the debate that Dr. Merson mentioned about the Sustainable Development Goals. We are coming towards the end of the MDGs era, and there are lots of folks out there who are estimating what they think, for example, the maternal mortality ratio could feasibly be by 2030. The SDGs are going to have a 2030 end date. And some of the estimates that we've heard are very much in line with what we've modelled, and some are less aggressive and some are more aggressive. So it'll be interesting to see how the final targets are set. We are doing a lot of work with the Open Working Group on the SDGs, the group that's writing them. In fact, they've started writing them this week to brief them about our work. Many people have asked us, well, the SDGs are going to have a 2030 outcome. Yours is 2035. What does your modelling show about 2030? So we've also modelled these to 2030 and are feeding our estimates into that process. I like to say that you can tell that our group was completely independent of the UN process. In fact, that's turned out to be a great strength, because unlike everyone else who's doing 2030 modelling, ours was to 2035. By 2030, not surprisingly, you won't reach as low a maternal mortality ratio or under 5 mortality rate as by 2035. But you'll still converge with other high-performing middle-income countries. This is a bit cute, but you could converge with the 3 Ps, for example, Panama, Peru, Paraguay, which have under 5 death rates of about 20. You may have seen Richard Horton wrote an editorial in The Lancet posing the notion that perhaps this grand convergence idea could be the Sustainable Development Health Goal. There's a lot of discussions and debate and jockeying now about what those goals are going to be. There are actually 19 areas this time round rather than 8. There will be one health goal. And he wrote this quite bold editorial suggesting that the grand convergence might be the SDG. Now, I don't know if that's going to happen. As I said, we're certainly trying to share our independent modelling with the committees that are shaping these. But we are finding tremendous excitement and interest in this grand convergence notion. It's a simple goal, it's overarching, it's cross-cutting, it doesn't pit different disease communities against each other. Everyone is represented in the reproductive, maternal, newborn, child health and infectious disease space. It's a prize within reach, within our lifetime. You can understand it, operationalize it, monitor it. It has this generational quality to it. And it's not just advocacy aspirations. You know, this is based on aggressive scale-up of a suite of evidence-based tools. So on reproductive, maternal, newborn and child health, for example, our model includes 51 proven tools, and it scales them up at a rate that we know is possible, because we use the rate of scale-up in high-performing countries of recent years. So these are not advocacy goals. These are modeled empirical goals. It's not special pleading by health. You know, health sometimes battles with climate and with water, and there are all these debates and battles that sometimes happen in global health and development. And we don't see this as special pleading. We see this as a real investment with real returns. Returns that go beyond GDP to value life itself. And as I'll talk about in a minute, universal health coverage, as I said, is so buzzy right now, and everyone's talking about it. And we have found a way, I think, obviously I'm a little bit biased, this was my sort of life for a couple of years, but we think we have found a way to talk about it that's a little bit more tangible than what you sometimes hear. And it's a way in which we argue that the first thing that should be covered are the conditions that are part of the convergence agenda and some of the essential interventions for non-communicable diseases and injuries. And we argue that for all of these investments in discrete interventions, whether they're domestic investments or international investments, they should always be accompanied by structural investments in the health system, which we cost out, so that over time these structural investments coalesce into a fully functioning health system that can deliver not just on the unfinished agenda, but also on this emerging agenda of non-communicable diseases and injuries. Now, of course, it's a model. There are weaknesses, caveats, challenges. It's replicable, at least, so that anyone in this room could go out and replicate it. But obviously, models always have uncertainty. We were criticized for not trying to model the impact of better water and sanitation, of climate change, and so on. We made the case that, first of all, the model that we use doesn't allow for that. Secondly, we still think that the fastest, most expedient way to rapidly reduce maternal and child health is through ensuring that everyone gets health services and tools. It does assume pretty aggressive coverage. Now, I mentioned how we did that. We used a so-called best performer approach. We looked at the countries that did the best in the last decade on scaling up tools like bed nets to protect against malaria, and we assumed that other countries could replicate that, but that may not be true. And then I mentioned how we put in an R&D multiplier into this model. We assumed this additional fall in under 5 mortality rate, and also in maternal mortality and AIDS and TB death rates. But what if there is no innovation in the next 20 years? Right? That's possible, and then we will have overstated what can be achieved. I think that's unlikely, but it's a possibility. And also, we may have underplayed what could be achieved. Our model is agnostic about what those tools might be, but if there's an HIV vaccine tomorrow, we're going to get there much quicker than we would have thought. We're doing some follow-up research. We're looking at 2030 modeling. We're mapping out kind of next steps in what you do with this convergence modeling. And we're doing more on kind of best performers. Which are the best performers and what can we learn from them? Our third message is that in the non-communicable disease and injury space, fiscal policies are particularly powerful. And we argue that the single greatest opportunity on the planet to impact on non-communicable diseases is tobacco taxation. Massively underused. Prabhat Jha and his team recently modelled what a tobacco tax would look like in China. A 50% rise in the cost of tobacco from a tax increase would prevent about 20 million deaths and bring in about $20 billion a year over the next 50 years. I mean, that's extraordinary. Saving 20 million lives and bringing in that much revenue. And of course, revenue will decline over time, hopefully, as people smoke less. But you'll still have additional revenues compared to today, even for the next 50, even over the whole of the next 50 years. And you often hear, again, I'm not an economist, but You certainly hear kind of libertarian economists don't like us very much. Some on the right don't like us because they're like, well, tobacco taxation is regressive, you're stopping the poor from having the pleasure of smoking. But when you look at the modelling, it's very clear that actually the poorest people benefit the most because they're the most price sensitive and they're most likely to quit. So the health benefits accrue to the poor. So I consider these to be pro-poor. We also argue, and this is obviously quite topical right now, to tax sugar and sugar-sweetened sodas, empty calories, which can reduce obesity and also raise significant public revenue. And again, there are studies to show that these are not regressive taxes, that in low-income groups, diet quality rather than not enough calories is the issue. So if you look at the lessons in general, we know these taxes must be large. You know you should think about tax avoidance through loopholes and tax evasion, through smuggling and bootlegging, regional cooperation, very important on those. Interestingly, you also need to think about substitution effects. It's all very well if someone stops eating sugar-sweetened food, but then switches to something else that's equally as bad for you, Pringles or whatever. So you have to think about the possibility of substitution effects. And as I mentioned, the low income and the young are the most price sensitive and are therefore going to respond the most. We lay out a suite of these population-based approaches, and we examine some of the clinical interventions that are crucial for tackling this global crisis of non-communicable diseases. And I know that some of you are clinicians or clinical students. We began by saying, look, the WHO has a package of best buys. It's a pretty limited package. Some people are distressed by how limited it is, but this is the WHO approach. They want everybody in the world to get the interventions you see in this table. So just 2 cancer interventions, Hep B vaccine to prevent liver cancer, and screening for cervical cancer with visual inspection with acetic acid and treatment of precancerous lesions. And then for cardiovascular disease and diabetes, cheap generic drugs, aspirin, beta blockers, and for heart attacks, aspirin alone, nothing more. That is the WHO package of best buys, and they think everybody in the world should have access to that. And we begin, you know, it's a bit of a no-brainer by supporting that, right? If you reached 80% coverage with all of those clinical tools by 2020, you would avert about 40% of the global burden of cardiovascular disease. And data from the WHO, not published but shared with us, show that actually coverage rates of those interventions, with the exception of Hep B vaccine, is very low across low and middle income countries. So you could have a large effect with just this package of interventions alone. So it's a very feasible first step, doesn't cost much. We argue actually that the HPV vaccine, the cervical cancer prevention vaccine, HPV, should be included. There was a recent price drop that makes it highly cost effective. And then in our report, you'll see that we then lay out a set of phased expansion pathways, right? And the choice of the pathway that a country takes in terms of adding more interventions is going to vary by what disease burden they have, what they can deliver, how much spending, and so on. So there is clearly no one-size-fits-all for how you expand your clinical suite of interventions. But we lay out potential packages that you could add as your resource envelope spreads, both at the hospital level and at the clinic level. So just for example, there's a basic mental health package that Ethiopia is now rolling out that includes a cheap generic antidepressant, a cheap generic anti-epileptic medication, and a cheap antipsychotic. The whole world should have access to at least those 3 conditions. And as I mentioned with the HPV vaccine, the whole equation can change sometimes overnight. You may have seen incredible news in the family planning world with a halving recently of the long-acting contraceptive, even a gestural contraceptive, overnight. Those sorts of massive price drops, this was due to innovative public-private partnership, they can change the game and might make it perfectly feasible for a country to add that intervention. And just a note, this is a quote I love to use from one of my co-authors, Margaret Crook, who, by the way, just launched a new initiative at Columbia University on global health systems. She early on in the creation of this report and during one of the meetings, she said that, you know, I'm finding that you're seeing these interventions as kind of like these atomized things that sort of rain down from the sky and just sort of deliver themselves. And we really have to be very careful in not creating that impression, that obviously interventions do not deliver themselves. They need health systems, and what we do in the report is to lay out 4 key platforms and the interventions, examples of interventions that could be delivered across each. And lastly, just in the last 5 or 10 minutes, I wanted to share with you our approach to universal health coverage, what we call progressive universalism. By the way, we've had some folks who haven't liked all of the terminology that we've used. So we presented this work at Columbia, and the ABC News editor was there, and he was like, "Convergence, that sounds like cars going into the Lincoln Tunnel. I don't like that." And then on progressive universalism, we've had people thinking it was like an American insurance company, that progressive woman on TV who's always trying to sell progressive insurance. Anyway, I digress. What do we mean? So this is an extremely famous cube that the global health folks will have etched on their brains. This is what we talk about when we talk about universal health coverage. It has 3 dimensions, and that is the interventions, which interventions, from 0 to 100% of all interventions, how much of the population, up to 100% of the population, and also how much is prepaid, and how much do you have to pay out of pocket. Those are the 3 dimensions. And as far as I know, and you can correct me if I'm wrong, I might be, I don't think there's a single country on earth that is at 100% on all 3 dimensions. I don't think there's a single country on earth that gives every single health tool and intervention to every single person where nobody has to pay. Most people are somewhere along the pathway, along those 3 dimensions. The crucial question in our minds was, how do you move through that cube? Is the idea that you should advance equally on all fronts, or is there another way of getting there? What works best, clearly, is going to depend on where a country is today. There is no one-size-fits-all approach to how you expand coverage. And what we argue in this report, and we think it's a way to start to put a little meat on the bone to think about UHC. We argue that as you are expanding coverage, as you are going for UHC, we argue you should focus initially on the so-called convergence conditions, infections, reproductive, maternal, newborn and child health, and this basic essential package of non-communicable diseases. That will maximize health status and it will protect people financially, so-called financial risk protection. Progressive universalism isn't our expression. It was coined in a Lancet op-ed by Watkin and Ergo. They defined it as a determination to include people who are poor from the beginning, and it builds on Gro Harlem Brundtland's new universalism. She was the Director General of the WHO. I had the great privilege of spending an hour with her. In 2002, I wrote a 5-part series about the WHO, which ended with an interview with her. And in her new universalism, she said, if services are to be provided for all, then not all services can be provided. The most cost-effective services should be provided first. So what on earth do we mean by progressive universalism? We argue that insurance covers everybody. So we are talking about everybody being covered with a package, this package that I mentioned for the convergence conditions and the essential interventions for non-communicable diseases, that are interventions that are highly cost-effective, and they are pro-poor because these are conditions that disproportionately affect the poor. They are funded through taxes, payroll taxes, general taxation revenue, payroll taxes, or both. There are no out-of-pocket expenses at all for this publicly financed package. And then as the resource envelope grows, as countries get richer, they can then expand what's in the package, typically adding more interventions for non-communicable diseases. That's exactly what we've seen in Mexico with their Seguro Popular scheme. One of the advantages of this approach is that you don't have to spend time and money figuring out who is poor and who is not. The entire package goes to everybody, prepaid publicly. And the fact that everybody gets it has proven in many countries to be very valuable politically, to garner public support and indeed provider support as well. We lay out a second pathway of progressive universalism in our report, which Rwanda is now adopting, where you can actually give a larger packet to the whole population right from the start, but you therefore obviously need to have a wider range of ways to fund it, typically by adding compulsory insurance and co-payments. It's kind of the Affordable Care Act model. You then clearly have to subsidize the poor. So in Rwanda, which does have this second variant of progressive universalism, the poorest pay no premiums and no co-payments. In fact, donors are covering the costs of those. So it has advantages. It's a bigger package, and it engages people in a mandatory insurance scheme from day one. And in some countries, paradoxically, the transition to this kind of progressive UHC might be easier, because in many countries, out-of-pocket payments is how healthcare gets funded. In fact, in most of the poor world, is that true? About 60% of patients in sub-Saharan Africa, 97% in Bihar, they are going to see private providers and largely paying out of pocket, and it's chaotic. And this would introduce sort of structure and organization to what is already sort of a chaotic out-of-pocket arrangement. But if you are wanting to subsidize the poor, it does mean you have to find out who they are, which can be quite costly. There are benefits to progressive universalism. The poor gain the most in terms of health and financial risk protection. The approach yields very high health gains for every dollar that you spend. You're using public money to address the negative externalities of infectious disease transmission. And many countries have shown that it's feasible. We've got plenty of countries that we can draw on from their experience. Rwanda, I mentioned. Mexico, I mentioned. Ghana, Thailand, you all have others. So I wanted to just finish off just giving you a little bit of a flavour of what we're doing. The report came out in December. We launched it in 3 countries. And also at UCSF, it was wonderful. We had Larry Summers and Dean, the chair and co-chair of this commission. And also one of our authors is Ken Arrow, one of the world's most famous economists. He won the Nobel Prize. He's 92, and it's really amazing. Ken Arrow is actually Larry Summers' uncle. And despite both of them being kind of world-famous economists, they had never been on a panel together. So I had to take a photo of the two of them and send it to Larry's mum, which was very sweet. We've been briefing the UN and the UN Foundation. I had the bizarre, surreal experience of going to Davos, the World Economic Forum in Davos, and mingling with all these famous people. And so we ran an event with Bill Gates. We had an hour with Bill Gates to brief him on this, and then he did an event at Davos with Larry Summers and Jim Kim from the bank, together with Leela Maholo, the governor of the Bank of Botswana, one of the most impressive bankers on the planet. We've done launches at Colombia. We've briefed a bunch of donor agencies, bilateral donor agencies. Next week we're briefing the USAID. On my way back to San Francisco tomorrow, I'm stopping up at the CDC to present this work, and we've got upcoming presentations at Imperial in London and Yale. We've got the chance to brief Secretary Kerry later this year, Parliament in the fall, the UK Parliament in the fall, and we are in the process, hopefully, of launching 2 national commissions on investing in health. One in a low-income country, one in a middle-income country. This is a way for countries themselves to take this report and see what it means for them. How would they achieve convergence? How would they personally raise resources for it? What does their health system look like? How would it need to evolve? So we're very excited about the possibility of those national commissions probably launching next year. And just some final reflections about some of these events. We have found the notion of convergence to be one that people find quite powerful, but as I said, the word isn't always loved. We have found our independence to be very powerful. When we turn up at the UN, people at the UN are being lobbied now. Like every single day, some advocacy group is turning up to say, oh, we hope you include toenail fungus in the SDGs or whatever it might be. Whereas we really are not an advocacy group. We are saying, look, we've done this empirical modeling. We think it can inform the targets. And we have found that to be super helpful. And we've also found that this notion that, it's cross-cutting, it doesn't pit diseases against each other. There's even UHC in a sort of tangible way of expressing what universal health coverage means to us, has proved to be very valuable. So I thank you very much for your time. Twitter questions via the hashtag GH2035. You can follow us at the @Yamey or at Global Health 2035 handles. You'll see that I started the Twitter barbecue war, to be continued, but it's mostly about global health. So thank you very much.
Gavin, thank you for that talk. Actually, now I'm going to introduce our panelists, each of whom will speak for a few moments, and then we will move to our question and answer session, assuming I can read this thing through my bifocals. All right. I have our three panelists here. Our first is Dr. Mohammed Pat. Mohammed Pat was named Minister of State for Health in 2011 in Nigeria, and actually led the coordination and implementation of the African nation's primary healthcare system. He is credited for Nigeria's bold efforts to expand vaccinations and access to essential healthcare services for women and children by 2015 through the Saving 1 Million Lives initiative. I would also mention that Dr. Pat ran and worked on an amazingly innovative and successful polio initiative, anti-polio initiative as well. Dr. Pat received his medical degree from Ahmadu Bello University in Nigeria and has graduate degrees from the London School of Hygiene and Tropical Medicine and from right here at Duke University. Our second panelist will be Papa Guy, a native of Senegal. He is currently president and CEO of IntraHealth International. Guy began his career in international development as a trainer of Peace Corps volunteers in Senegal and Benin. As the director of IntraHealth International's regional office for West, Central, and North Africa, Guy focused on improving the performance of health workers and health systems to more effectively serve clients and communities with quality care. He holds an MBA from UCLA, and has previously worked for the 1984 Los Angeles Olympic Committee, I didn't know that actually, and the Centers for Disease Control and Prevention. And next we have Alex Deegan. He is a senior visiting fellow here at Duke and the former USAID chief scientist. He is the founder of a new startup, Conservation X Labs, and as I said, senior visiting fellow here at Duke University. While here, he's focusing on three major initiatives. First, innovation and entrepreneurship. Second, globalization. And third, the Tropical Biology Initiative. Deegan most recently served, as I said, as chief scientist at USAID, and he had the rank of assistant administrator, founder and headed the Office of Science and Technology. In 2013, as he's also a Duke alum, I should add. In 2013, he was selected as a 40 by 40 fellow for the American Association for the Advancement of Science. And this was for his exemplary dedication to applying science to serve society, saying that his dedication and his ideas were creative, innovative, and collaborative as he worked towards solving problems and global health challenges. So with that introduction, each of our distinguished panelists will have up to 5 minutes to present their comments on Convergence 2035. So we shall begin with Dr. Pat.
Well, thank you. I think Gavin has given a very impressive presentation of quite a very detailed piece of work by the Commission. It's obviously a very impressive and optimistic view of where we are in global health today. But I would like to make a couple of points. First is that yes, in fact, in terms of inter-country differences, we may be experiencing global convergence. We also need to be mindful of the intra-country situation. In certain countries, the inequalities and inequities in access to care and distribution of outcomes would exceed the inter-country differences. I'm not sure this has been reflected in terms of the work of this global convergence. It's more about the inter-country differences that we're seeing in this global convergence. So the poorest within countries, the movement of population, urbanization, the urban poor, and the health situation of the urban poor can be missed within this average that is actually converging at the country level. The second point is what Gavin mentioned regarding the fact that the returns on investment for the intersectoral actions for health have not really been factored in the model. And yet we know that the last 10 years have seen unprecedented pace of economic growth in most countries, including in Africa, where the preceding 10 years, when the investment in health 1993 was done, really many African countries were not growing at all. And so the intersectoral actions, water, economic development, nutrition, all of those can have a profound impact in terms of health outcomes that we're seeing, but that has not been factored really in terms of the analysis of this. Thirdly, the issue of population dynamics. I think the demographic dynamics has been mentioned, but we know that there's no one uniform trajectory, that there are several countries in the world where the populations are shrinking and where some populations are actually growing quite fast. And with that, even the timing, the synchronicity, when we're going to see these NCDs actually will differ from country to country. So we have to be mindful of that fact as well. The fourth point is regarding the universal health coverage debate. I think it's the buzzword now in global health, and as we get to 2015 and beyond, it's going to be. And I think it's an aspiration that we all subscribe to. But on the other side, I think the Commission was able to sort of make the statement that every country will have to find its path. Thailand took almost 30 years. China did over 2 years. And linking attainment of universal coverage with improvement in health outcomes and showing the evidence for that, I think we're not yet where that has been conclusively demonstrated, even though access and financial protection are important goals for health systems. Finally, the health system constraints that would have to be relieved, I think were mentioned in the report, but the fact is many countries have mixed health systems, and the role of the private sector and unleashing the potential of the private sector to be able to deliver what we need to deliver will be key to continuation of this convergence. And similarly, beyond looking at health from primarily the consumption side, which is sort of which traditionally ministers of finance might look at it, you expand or investment in terms of the returns, but it's also potentially a growth sector. So in the United States, 1 in 8 new jobs recently are actually in the health sector, because the significance of the health sector as an employer, the innovation, the industry, the entire health value chain. And so there may be other opportunities for finance ministers and others to look at the health sector, not only as a sector that basically delivers services, but it also contributes directly to economic growth. And I also want to finish by saying that while we should be optimistic, I think we should also be realistic as to risk. And I think the Commission laid out some of the potential risks that we might experience down the path. I mean, things like the pandemic preparedness and what it might mean as we look long term, I think we have to be mindful of. But overall, I think it's an excellent piece of work. Thank you.
Thank you very much. Bob Guy?
Yes, I wanted to react also to the four key points that the report is trying to make. And I'm generally optimistic as well. I think, like Mohammed, my questions remain, everything is in the details, right? And I think because of the expectations that domestic financing is going to follow, that's where I have the biggest question mark when it comes to, the ideas I think are very powerful. I think investing in health is the thing to do, and it makes economic sense. I think the grand conversions can happen, but I want to reserve judgment a little bit because I want to come back actually to the role of international organizations, since I represent one, and talk about what I think need to happen from the point of view of those international organizations for us to achieve these objectives. The fiscal policies, I think those are very sound, and they are pressure points that I hope we can succeed in making the governments do. But that's where I become a little skeptical, is that are we going to really be in a position to get these governments to exert that kind of pressure? And then universal health care, the buzzword going on. I guess my question is, are we really going to be aligned in what we mean? Because I think that's where the danger comes. I think the interpretations are many. And this is room for political, because a lot of the countries are going to use it for political purposes. So I wanted to, before I make my comments on today's landscape and what international organizations need to do, I went back to the report and I looked at what was described actually as challenges. Well, first of all, the 1993 report did talk about fostering an environment that enabled households to improve their health. It talked about improving government spending on health. And that also talks about promoting diversity and competition in the supply of health services, meaning that we need more actors. So I'm citing those because it's interesting to look back since 1993 and see, and it seems to me that we are still talking about the same challenges. So that's I think, room for pause a little bit. There's also some place in the report where they talk about how globalization could actually impede the future of health progress. And it was cited in there as a major challenge, the brain drain, the local spread of NCDs, risk factors, and the global climate change. I think those will continue to be challenges that we will need to address. So ask me what I would do in terms of supporting the direction that the report should do. I would invest clearly in health system. When I see the price tag, it scares me a little bit because in the lower income countries, it's going to be between 40 to 60% or even a little bit more, and in the medium income, so it's still a very high price tag. And I know it includes a lot of factors. It includes commodities, it includes, but it's a high price tag, and so, but that's what I would do. I would really follow this structural investment in the health system. I think we should find a way for every global project or local project that we do to dedicate a portion of those resources to strengthening the health system. I think we definitely need to continue to invest in the health workforce. I think this is a big one that happens to be our line of work. I can talk a lot about this. I do think we need to invest in community health workers, especially for sub-Saharan Africa and so forth. Let's face it, it'll just take us so long to get enough doctors and midwives. So I think not investing in community health workers would be a mistake. And I do think we need to engage in transformative education, but as it is now being discussed, where we put the emphasis on recruiting future leaders from areas where they're going to serve to curb the possible retention issues. We need to invest in decentralized training institutions because we still have too many institutions that are in urban areas and so forth. We need to include a systems approach and a systems thinking in our curricula. It's definitely the next generation, you guys, need to hone in and sharpen those skills about problem solving, global thinking, systems thinking. And I think we need to find ways to better harness all the technology platforms that exist. This direction, Global Health 2035, has huge implication for how INGOs need to behave, in my opinion. There are a lot of changes. This landscape has changed incredibly. In the last 5 years only, you can say you've got now the traditional NGOs, like I think we fall into that, although I think we have very futuristic thinking. I think you have to look at the academic world, students, faculty, research, the way they're wanting to engage. It's new and different. I think you really want to be out there, so I think we need to make room for that. We need to make room for the new social entrepreneurs. I mean, they're coming, they're doing things, they're creating things, putting tools out there, and we are all talking about the private sector. So, whether you want it or not, this field is changing. It's going to continue to change. So, we need to find ways to make room for all of these new actors and do a better job of coordination. So, what does that mean for what exactly INGO will be doing? I like to think about it in terms of a continuum. I think you have a continuum that goes from you're implementing for USAID or CDC or something, or you could go all the way where you're advising government, and you can, maybe there's something around intermediation where you understand the realities of the field, you understand what the donors want, and then you try to play that role. There was a recent report commissioned by the Hewlett Foundation and implemented by a group called FSG. If you have not seen the report, I'd recommend it very highly. The report that was published out of that study is called Ahead of the Curve. And it was after an interview of 50 leaders of INGOs, from large ones to medium size. And it really talks about this shift that needs to happen with the INGO communities. I think it's interesting. It talks about focusing more on systems and system strengthening. It recommends doing more with advocacy, because that is one piece that we need to help countries. And it talks a lot about embracing the private sector and working in this, finding the value proposition and so forth. So very interesting, but clearly changes are happening. We can talk more in the question session, but the field is not the same. I think it's dynamic. I think you guys, younger students, new entrepreneurs, I think have a time horizon which is much shorter. It's interesting to find ways for development to embrace some new way of thinking and so forth. So I'll stop with those comments, and then we can always come back. Thanks.
Alan?
Just as a first point, I want to totally agree with what you just said, yeah, and I think that's spot on. Also, to downplay expectations, it is not only Global Health Week, it is Lemur Week, and although I am neither a global health professional or an economist, which I think also would be incredibly valuable, I am a development professional and a lemur specialist, so you'll get my perspectives from that. I think this is an extraordinary report with extraordinary ambitions, and I think optimism is actually good and necessary in things like development and in science. And then goals are incredibly important in international development, and it takes courage, I think, to set goals. One of the things you get from reading this report is not only the incredible ambitions of the report, but the fact that global health is not just a medical field, but it is an anthropological, a sociological, a legal, and economic field as well that has to be part of that calculus. And again, I think it gets at the systems approach at what you're saying. One thing just in general from my former employer, USAID's perspective is I think research and development in science and technology and innovation are going to be critical in being able to move the ball from the linear to the exponential in our ability to address some of these problems. And this isn't not just in terms of ideas that are coming out of the West, but ideas that come from anywhere in the world. What we recognize is the limiting factor is opportunity, but not necessarily that good ideas can be found everywhere. And this includes South-South cooperation, frugal design, and we have to take advantage of what's called the democratization of science and technology. And in fact, this week, on Thursday, Secretary Kerry will be launching something I created at AID, the U.S. Development Lab, sort of a DARPA for development, specifically to help us do so. I do think that there's a lot of assumptions regarding the convergence that we need to think about. I also want to just point out that the report is incredibly self-aware of some of these assumptions. The real pivot, and I think discussion point, is how much these assumptions really matter and will undermine. And the one thing, I'm an optimist. Just you work with lemurs, you have to be optimistic for a place like Madagascar. And I don't want to dispel or undermine anything that these guys are doing, because I am all for it. The first one is the report really focuses on health, but the fact is when you're thinking about what infrastructure is needed, many of these countries that developed also made significant investments in energy, clean water, food security, communications that are actually equally important in terms of health outcomes. So if you're looking at a cost of $23 billion a year just for those health infrastructures, I think that greatly actually does not represent the true number of the infrastructure investments that are there. We have seen that investments in education, in food security, and water can have substantial health impacts. Open air defecation in terms of its impact on things like the microbiome in individuals and their ability to even uptake things like vaccines is something that sort of emerging research is pointing out. There's going to be costs as a result of better health. What happens when the bottom billions want air conditioning? What does that do when it takes coal plants to actually produce that? What are the costs in terms of food security? The general statement is the price tag of these investments is probably much higher, that countries like Indonesia, Egypt, Turkey, Chile, Costa Rica, China have made those huge investments in the infrastructure outside of health, and that's something that we have to think. Are these representative models? Does the convergence actually capture these externalities? The second point is I think there's some assumptions about, A, the funding of the initiative and the sustainability of that funding, and then just in general, whether it is possible there's the coherence, cooperation, collaboration, both internally within countries and within the global community for things to happen. Just coming from Washington as of yesterday, there is not that in our Congress. I can now say that, having left the U.S. government. But it is, there's a fundamental assumption. Increased economic growth will not only contribute to an increase of funding overall for global health, but that countries will actually be able to spend a greater percentage of their revenue streams on global health, that there will be greater efficiencies of global health spending and a greater ability of donors to contribute to global health. And I think those are pretty fundamental assumptions. And it's going to compete when those bottom billions, as they move into the middle class, want energy, they want streets, they want educations, and it'll be competitive against which of these pathways that we actually take. I also think there's some really big uncertainties, which the report does acknowledge briefly in terms of the impacts of things like environmental degradation and climate change that can be equally catastrophic to countries as health events are to individuals. Do countries actually have the ability to raise taxes? This is a really serious problem in the developing world. Countries can't enforce billing for things like electricity, right, or water services. So how do you actually develop the governance systems that allow that to happen? The key to taxes are the abilities to enforce them. There can be a huge lag time between the cost benefits that come out because of these global health benefits and when those returns are actually made. And there may be a disconnect between the recipients of the benefits that may not be co-equal with those who actually bear the costs. And that's something, these are just things to think about, and again, not a criticism of this approach. And then finally, there's one other question, which is, at AID, we, particularly within this administration, it's no longer we, but we made an effort to actually do much more things through local institutions and national governments. What we found is those governments actually do not have frequently the capacity to quickly scale up and absorb large increases in the expenditures. And there needs to be some consideration of whether we can do so. And I think just third, and the last assumption I'll sort of talk about, is many of the changes in development are not, and this is coming from the Science and Tech Advisor, Chief Scientist, are not around technology or research, but the scaling up of technology, right? The translation of R&D into practice and implementation science. And that is where research, technology, and science meet human beings, right? And cultures and individuals. We know a lot of solutions. We still haven't yet fully scaled up oral rehydration salts around the world. Why is that? We have many great technological breakthroughs that have not made it through. And in fact, USAID has set up a Center for Acceleration and Scale run by Wendy Taylor, another Duke alum, specifically to focus on this. And I think the last point is universal health coverage, and I like how they have addressed it, is a governance challenge. And we can only look at Medicare within the United States to just look at the scale of that challenge. And again, I think this is something that it's a problem we have to address, and we just need to address it head on. A couple of rethinking of assumptions. Are there ways that we can get at this not through national governments? Is there a way to create health return bonds where there are investments made that arbitrage the current cost of the disease to governments and societies against the value of future avoided treatments, disabilities, and deaths that could be actually taken by the private sector? Pay for performance measures. Are there private sector solutions to treatment and giving of health? And I'm not talking about insurance, but actually private clinics, and some of the experiments are going on within places like Kenya. Can we leapfrog some of the infrastructure investments? Because it's not building hospitals, it's providing care. So if you can provide point-of-care solutions through technological solutions that eliminate, we have $900 sequencers now. We have new ways we have handheld tools that have been developed through my office, for instance, that not only tell you what kind of HIV, whether you have HIV, but tell you through nanotechnology actually the type of HIV that you have in the field on a battery-powered device. How do we leapfrog that infrastructure to have those cost savings? And we should think about things like open source drug discovery models from India and really think about the IP questions around the R&D. It almost seemed like the R&D component of this was a black box, and I think that's one of the areas that we have to think about. Thank you.
Thank you very much. Thank you, panelists. And now, Gavin, may I invite you back to the podium? And thank you so much. And what we will do now is we'll have questions from everyone. We will alternate among Twitter and people in the room. So, and then I reserve the right to ask a question or two myself periodically. And before you, would you like to begin? Yeah, because he's so excited. We'll begin with Dr. Tong, and then we'll ask our first Twitter question. Go.
Gavin, thank you very much for such important presentation and marvelous report. I fully agree what the panelists said. This is very ambitious and optimistic. I'm always optimistic, but this time I'm probably a little bit, optimistic about the progress that we will make in the next 20 years for quite a number of reasons. Given the time constraints, I just want to make 3 comments, observations. First is financing and resources allocation. It is possible for the international communities, for the national governments to mobilize resources, as you raised, 70 billion a year for health interventions, over 3 billion a year for R&Ds. That probably is feasible or practical. However, there might be a problem of resources allocation. How these money is allocated for different health interventions, how these R&D money is allocated for different health needs. The 1993 World Bank report wanted to invest in most cost-effective interventions. If you look back 20 years, not always cost-effective interventions because of the political reasons or other reasons. And also look at the R&D. I'm pleased to hear the last panelists mentioned. For example, R&Ds, maybe it's possible to raise over 3 billion a year. But look at all these allocation of the R&D research monies. And these health needs, diseases most fits in the lower and middle income community, only attract less of amount of monies. Second is implementation science. Actually, when I was in TDR, we did some study mapping out the flow of the R&D monies. And big funding agencies and started to reduce implementation research science. European Union is a typical example. They want to develop European knowledge economy, and they reduce the fundings for implementation science and increase the money for the basic science. So this is the first comments, observations. Second is that the burden of disease, the pattern of disease has been changed. very much significant over the last 2 or 3 decades and will change in the next 2 or 3 decades. Some of the challenges, health challenges, may not be fully recognized by international communities or national government. For example, injury. Given the economic growth, faster, Africa's injuries, huge problems. TB, MDR TBs. Last week, Lancet published a paper about how wonderful China's national TB control program was. Half the TB incidence of prevalence. But Lancet publishes such paper every 10 years for TB control in China, and the last, not this last week, the 10 years, the paper, I wrote a commentary about how the China or India sometimes exaggerate their achievement. MDR-TB has not been fully recognized. China has the largest burden of MDR-TB. Unfortunately, there are no national strategies tackling the MDR-TBs. Okay, so you map out also some promising TB reductions, TB deaths per 100,000 populations in the next 2 decades. I'm really much concerned about this. Really much concerned about this. And the third is about universal coverage. All this panelist has mentioned about universal health coverage through either the social health insurance or through the national health service like a British system. Many people thought, universal coverage are good things. Yes, I agree, but there are also negative impacts, which we haven't yet fully recognized. Universal coverage sometimes could stimulate the unnecessary over-provision of services, resulting in the rapid rise of healthcare cost. Politicians often use the indicators that fit their political agendas. For example, China actually started launch officially is universal coverage 4 or 5 years ago, but actually already started groundwork 10 years ago. Now they almost achieved universal coverage by 3 mainstream health insurance supported by government. If you look at the out-of-pocket payment as a percentage of total health expenditure, declined from 60% to 38% over the last decades. Wonderful. However, if you look at out-of-pocket payment as a percentage of average household consumption or average household income, increased. So yes, universal coverage through health insurance often require deductible payment, co-payments. The poor never afford the co-pays. For example, MDR-TB patient. There's no way for MDR-TB patient can afford the co-pays lasting more than 2 or 3 years treatment period. Even if now actually in China, the MDR-TB control, Gates Foundation work with us and try to ask the poverty reduction program to take the care of the co-pays. But even if you provide a free MDR-TB care to every MDR-TB patient, there's still tremendous indirect cost. Infrastructures, MDR-TB, not primary health care cannot treat MDR-TB. You got to go to the cities or prefecture levels, or hospitals, transportations, accommodations. So free health care sometimes not truly free. There are financial burdens. So thank you very much.
Thank you. Would you care to respond to?
Maybe I'll just make a few comments. Firstly, I completely agree that there is a lot that we still don't know about how to scale up and how to implement. Dean Jameson has coined a term that we use throughout this report called PPIR, Population Policy and Implementation Research. And when we call for the international community and for international collective action to step up its efforts in the research arena, we don't just call for R&D for new drugs, devices, vaccines, biologicals, etc., but also so that we better understand implementation. And diarrhea was mentioned as an example. WHO and UNICEF issued its recommendation on adding zinc to low osmolarity ORS like almost a decade ago. And the most recent DHS survey suggests that less than 1% of kids are getting that combination. More are getting ORS alone. So we've got a long way to go in understanding how to scale up. We've got a lot of unanswered questions about how to roll out UHC. And there's a tremendous avenue of research out there to be completed. I think the new initiative at Columbia that I mentioned wants to address some of those questions around quality and affordability and so on. The Commission on Investing in Health itself is trying to launch a movement to understand UHC better, the pathways towards it, how you finance it, how you protect the poor from day one, sources of revenue and so on. There's a lot we can learn from country experience, but there's clearly a need for empirical research as well.
So we have a question from the Twitter sphere, we call it, I guess, the Twit world, I don't know, from Tweet World, that's actually related to that. It's quite interesting, and it's from someone named Sylvia. And what Sylvia is saying is that some say we have the tools that we need, but we don't yet have the right delivery methods. So could you or anyone on the panel elaborate on the role that healthcare delivery innovation of tools that we have right now could play a role in the grand convergence?
No, I mean, it's obviously very frustrating and kind of tragic and appalling that for many conditions, it's a cliche to say it, but we know what works and we know the tools that would cut deaths enormously. The Bellagio Child Survival Study Group, for example, publishing in The Lancet, I think it was roughly 2004, 2005, they laid out about 20 to 30 evidence-based child health interventions that, if instituted today, would save almost all preventable child deaths. And yet coverage levels for many of those interventions are still depressingly low. So we need to do better at understanding how to deliver. And there is, fortunately, a new, it used to be called operational research. Maybe it's just a new branding, but certainly there is renewed attention to this frustrating cause of avertible mortality, and it gets labeled implementation science or delivery science. We now have a journal called Implementation Science. Jim Kim, when he was at Harvard, began a delivery science project. He has vocally committed. I mean, we've heard him in speeches talking about the World Bank getting more into the delivery science space. We are thrilled to have Ambassador Eric Gooseby, who led PEPFAR back at UCSF, and he is launching a new initiative on implementation science, and I believe Duke Global Health Institute is starting a sort of evidence laboratory, some of which will look at some of these questions. So I think this is a good time for those of us interested in this science of delivery, because I think we're starting to see a real movement in that area. It's never had necessarily the same sort of academic cachet or sexiness as, finding the next vaccine, but the impact could be absolutely enormous.
Sure. Yes, it was something that I thought about as you were explaining the strategies, is that the sort of decision-making matrix that we have to make and determine what are the best bets, what are the best buys. So I, thought immediately of something like the Copenhagen Consensus, which every 5 years or so looks at the top 20 best buys in the world. Many are specifically health-related, but many, such as education, right? Water treatment, as the panelists pointed out, are also as important and could have as major an impact. Now, the convergence document focuses primarily on sort of medicine, right? Focuses on health per se. But I think it's important to think about how do you see this Convergence 2035 fitting into this larger issue of also the evidence-based value of working with social determinants of health?
No, it's a very good question. Look, first of all, on the sort of Copenhagen Consensus and some of these other prioritization projects out there, we certainly drew upon them. When the World Development Report was published in 1993, Investing in Health, it was informed by the first iteration of the Disease Control Priorities Project, DCP, probably the most influential kind of priority setting project out there. And we were lucky to be able to draw on the third version. There was a DCP2 and now there's a DCP3. So in terms of prioritizing health interventions, we were able to draw upon that. And it is true that the Copenhagen Consensus, which regularly puts out its kind of best buys in development, it's amazing how many happen to be in the health sector. However, the focus of our report was not on the social determinants. We made an active decision to do that, partly because there have been a large number of incredibly valuable and influential social determinant reports, the Commission, obviously, on social determinants of health, and many other initiatives recently. So we didn't think that was our added value. And secondly, you'll see a few paragraphs at the beginning where we sort of lay out the case for why we focus on health. Partly because we still think it's the most rapid pathway for quickly reducing avertible maternal and child deaths. Partly to keep the momentum going in the post-2015 era around health. But actually, it's absolutely true that that we may therefore have underplayed or underappreciated how quickly we could reduce mortality. I mean, if there's great movement on education, on water, on climate, on sanitation, on all these other sectors, our modelling, underappreciates what can be achieved. You'll see that along with the report, the Lancet commissioned 5 editorials from the head of the World Bank, the Global Fund, and so on. And one of them was by Helen Clark, administrator of the UNDP, and she really did criticize us quite heavily for not saying enough on the social determinants. And we're open to many criticisms in this report, and I think that's a very valid one. Another criticism that I think is perfectly valid, and we heard about this a lot actually from the panelists, is that we don't really say enough yet about the political economy of how this gets done. I never knew what political economy was until recently. The notion of, in the real world, how would you actually do this? And so in the next phase of this work, we are starting to look at some of these political economy questions. It's all very well for us to say country X should slap a big tax on tobacco, but we don't really say how country X would do that and who would be in the way, and what would the electorate have to say about that, and all of those things. So we need to do more on the political economy front for sure.
Yes, and I think when I read the document, I didn't really read this as an either or. Right, so you should follow 35, not think about social determinants. I saw this as being just focused more on health interventions, though what struck me is the amount of overlap between the health-related interventions and those specifically health-related interventions that were in the most recent Copenhagen consensus. And in fact, you just raised a point that someone sent us in. It's someone named Ishan. And actually, where was it? And it was actually asking a question for you or anyone else. And different countries have different fiscal and political environments, right? And so how will those differing environments have an impact on this idea of progressive universalism in healthcare coverage? And I can open that up to any or all of you.
I'll take a stab at it. I think it's all contextual, and that's why I think we're onto something, and I think the report is onto something. I think this idea of identifying these core functions for the global community to focus on, I think is very powerful. I think we suffer from a world where there are too many implementers. It's very hard to find donors who don't want to implement too. And I think it has become problematic because you've got so many people wanting to do it their way and so forth. So I think it's going to be very healthy in the years to come to change the conversation and to fight the right fight. So that's why I think actually if the international community could really focus on creating, generating, nurturing, disseminating these global goods, which I don't think any individual countries can do alone, and then let really the implementation stuff at the country level. I mean, that is the task that we have at hand. It's much easier said than done because there's so much at stake and there's so much structure that is already built around the way we do business and the way the donors behave and implementers behave and so forth. But in the end, I think we have to accept that you're going to have these differences in countries. So the pace at which people reach UHC or whatever, it's going to be different. And the how is going to be very different, and the political context. So I think we can be supportive by, again, respecting that sovereignty and the fact that you do need local leadership to be able to make progress.
Absolutely. Thank you. Good. May we have a question from the audience? I see.
Thank you. I'm Septina. I'm with Wake County Commission for Women. And the question is actually for Dr. Yamey. It's a clarity question. You said that you want countries to commit to the $70 billion for 2035, but did you also have a framework that dissects countries that have emerging conflict, and do you have a provision to critically explore that and how they can reconverge post-conflict? That's my question. Thanks.
That's a brilliant question. So just to clarify, what we did was to ask the IMF and others to estimate what GDP growth looks like over the next 20 years. And our numbers suggest that if countries were to set aside somewhere between 1% to 3% of that growth, they could fund a large part of the convergence themselves. But as I mentioned, not all countries are going to be able to get there. Conflict states are a particular problem. We say very little about fragile and complex states in our report. But it just so happens, as if by magic, if you go to the BMJ today, the British Medical Journal blog, I have a blog on that topic. And the reason I blogged about it is that 2 weeks ago, I went to one of the most incredible meetings of my professional life. It was a privilege to be at that. Stanford, UCSF, and UC Berkeley. It's the only time in my life where I found myself sitting at a table, and to the left of me was the guy who ran the counterinsurgency team in Afghanistan, and to the right of me was Eric Gooseby, who ran the world's largest global health initiative in history, PEPFAR. And the whole purpose of that meeting was to get academics, global health folks, political scientists together to figure out this issue of the crisis of avertible maternal, newborn, and child health in fragile states. We, as a global health community, have done poorly in thinking about and addressing those deaths. The so-called direct deaths in war zones and fragile states, they get attention, they get the attention of the humanitarian enterprise, but actually there are more women and children dying from these so-called indirect deaths, maternal, newborn child health conditions, diarrhea, pneumonia, malaria, neonatal disorders, than from the direct deaths, and they're completely off the radar of the global health community. So these 3 universities are trying to start a new academic enterprise to start to look at those, and it does beg the question, well, you know, what role can universities play? I mean, what are these academies on the West Coast thinking? But there are precedents. Stanford has been working with the UNHCR on sort of designing better refugee camps. There are research studies, there are empirical studies to be done on the needs, the health needs of people in those situations, on ways that you could bypass sort of governance blockades. There are examples of sort of vaccination ceasefires where you're able to broker a truce. There are examples of using mobile technologies during elections to prevent election violence. Maybe there are other ways to bypass some of these governance blockades. And there are ways in which you can work with so-called kind of islands of integrity. Even within some of these states, there are NGOs, there are community workers who can be mobilized. Eric Gooseby shared the story of when the Global Fund started to work with the DRC, with the Congo. They were able to find NGOs. They were NGOs who had never worked in the health sphere, but they got cajoled and, and they were able to find willing partners. So I think we said too little about fragile states. And we haven't run the numbers, but my hunch is that if we were to ignore states that are fragile or where governance is weak, we would not converge. So it's a very good point.
And I would think in particular if you, since in the goals, we want to complete the unfinished work of infectious disease, right? If we aren't dealing with injury, violence, and disaster and the infectious disease issues that ineluctably follow, it's going to be difficult to meet that. It's a good point.
Absolutely, and George Rutherford from UCSF made this point that in some ways emerging infections are almost a marker or a symptom of governance and democracy.
Yeah,
the breakdown of governance is often, the trigger to emerging infections.
Well said. Will has tweeted in the following question. What role will private pharmaceutical industry play in R&D for orphan diseases, tropical diseases, and other diseases that are faced primarily in lower and middle income countries? And how will they be refunded, or how will they recoup their developments? Anyone?
Well, I think they have an important role to play, just as from the government, regulators, in terms of simplifying the regulation and incentives for pharma to take drugs that are on the shelves or from their research to trials and to the markets. Funders have a potential role in terms of earmarking that demand, which will signal to the pharma industry itself that, in fact, the market will be there, because some of these neglected diseases, it's not as if these drugs are the most profitable. I think it's not only the pharma industry that has a role to play in solving this issue, but between governments, industry, but also some intermediators like the Gates Foundation and others who can facilitate making the market work for production of these new drugs. I think that's, yeah.
Yeah, I can't help it but think about one comments that were made in the 1993 report about the criticism that was made by encouraging a lot of the private sector is when you work in an environment where governments or countries don't have the ability to really regulate. So I think there is room for the global community to come together to address the issues of regulation in order to just have safeguards and so forth. But clearly, I agree with Mohammed. I think they have a great role to play.
Just two really quick thoughts. Things like advanced market commitments, where there's a consensus on what needs to be developed, and actually having coordination among donors to say, we'll commit to buying X number of units of this drug at this price that can cover the incredibly expensive costs it takes for drug discovery. But just going back to open source drug discovery, which has developed sort of new variations on drugs that were less bitter, that were easier to take. It was 7,900 different scientists from 120 countries that participated in open lab books, shared information, distributed discovery for drugs that were IP-free. What was really interesting was the majority of those scientists were actually from pharma. So there was an interest in pharma to be able to spend time to do this in terms of what they got out of it. But I think that there has to be some changes, or thinking of the IP infrastructure, which has really become a barrier to innovation in some ways, and what it means in terms of global public good.
Right. So I know that I know that one of the proposals for how to increase research and development for, say, neglected tropical diseases is actually to establish a system of prizes. Right? It's the POGI argument. Do you think that use of prizes will be effective? Just curious.
Well,
or anyone, I'm just curious.
I mean, my office set up working with Gates, Grand Challenges for Development, Saving Lives at Birth, and prizes. I think prizes work when you actually have them long enough and consistent enough to actually, because I think prizes initially source existing innovations, but don't result in new innovations being developed. Mm-hmm. But over time, the hope is, and both Gates and USAID has seen this, is the development of new innovations when the funding is consistent. So I think it's not 100% determined whether it'd be useful for things like vaccines. It could be useful for tools that will help with healthcare delivery at point of care. We're a big fan of prizes in terms of we've been completely surprised by things like the Pratt pouch and uncovering those types of innovations and bring them to the fore.
Great, thanks. Question from the audience. Shall I recognize Dr. Merson? I guess so. All right, Dr. Merson, please.
I want to bring us back to the report and political economy and reality, okay? So in 1993, when the WDR came out, let's remember that launched some really exciting things. Mm-hmm. World Bank really gets into health, mm-hmm. right? UNAIDS is formed. Now we're turning around 2000, we get the Global Fund, and we get PEPFAR soon thereafter. And along the way somewhere, the Gates Foundation starts to invest $2 to $3 billion a year in global health. And we get up to these astounding figures, and then we get the MDGs, which people sort of fall asleep about until the last 5 years, when there's a real rebirth around at least the child goal and the maternal goal. Mm-hmm. All right? So I'm trying to figure out, where is the leadership going to come for this report? Because the leadership in 93, the bank got in, the Gates got in, Gates Foundation started and got in. We created some new entities like the Global Fund, UNAIDS, Global Fund, PEPFAR. I'm trying to understand, Gavin, I should start with you, but anyone, how is it going to really happen? Of course, at the country level, as you've already heard from Pop and Mohammed, things have been done this way for a long time, and there are a lot of actors right now. You've all seen the slide of the actors just doing HIV in Tanzania, this slide that's gone around for years. So I'm trying to think, when you did this report, except the modeling and the financial analysis, which is great, what was the thinking? Is there a new agency that's going to come? Is WHO suddenly going to become a leader again? Unlikely. That one we can put aside. So seriously though, where's the leadership that's going to make this happen? This is the thing I'm mulling over the last hour, hearing you and reading and seeing. No doubt what could be done, but just thinking, any of you thinking, what's going to predict the next 10 years in leadership and in governance that's going to make all this happen? Assuming, let's say all your assumptions are right.
We have an implementation science question, I think. Yes.
Exactly. Well, so we are sort of mapping out a kind of 2014, 2015 strategy to sensitize folks to our findings, to seek out key opinion leaders. We have our commission itself. So our commission includes ministers of health, ministers of finance, leadership at WHO, the bank, and so on. So they themselves are taking the messages to their constituencies. Unusually for a report like this, a lot of different agencies were involved in its creation. So there is some buy-in from those agencies already. We have been thrilled that Bill Gates himself has taken up this report. So we've had, we went up to Seattle to meet with him, to brief him on this. He is helping in terms of kind of getting the message out there. We have started to be approached by donors themselves to ask us to help them think through their future aid strategies in the light of this report and what it might mean for them. And obviously that's another potential lever. We think that if we can we have the potential of 2 country-based commissions off the ground. That is another way in which the report could be kind of operationalized in that way, what it means for individual countries. It's true that when the bank publishes a report, it has the machinery of the bank, that can then spread the word worldwide. We don't have that machinery, so our effort is smaller than the bank's effort. Larry Summers, who chaired this process, has been incredibly engaged in this report. He'll be presenting it at the World Bank next Friday at the spring meetings. We have an opportunity to brief a very large number of finance ministers from low-income countries at the Harvard Ministerial Forum. So we are we are working along these different avenues, and we'll see.
Mohammed?
Yes. I think a few decades back, health for all by the year 2000 was... No, but I'm just saying that the challenge that you've identified, I think, is a real one for a report like this. And its likely success in getting traction would depend on how well it's anchored around the SDG conversations. Because then at the heads of government level, once there is that buy-in, then you have the various UN, WHO, World Bank, country mechanisms actually keying into that. But you also have at the regional level a bit of discordance. So sometimes, okay, this is 2035, so the next SDGs, what's the time frame for that? Is it 2035 or is it 2030? And so the aspiration and the synchronicity of that. In Africa, I know the AU has a much longer term 2063 agenda that is working out. So anchoring this within particular either global or regional governance mechanisms will make it much more likely that then you'll get traction. Otherwise, it will just be a report that can be referred in 20 years to look at how far we've come.
I think I'm go a little bit that way. I think there's going to be a leadership, but I think it's going to be a different leadership. I think if we embrace what Alex is saying about the democratization of information, the accessibility, I think people are going to start accessing information and reports in a different ways. So I think you're going to see a different kind of leadership. So the real question you're asking is kind of a global governance, really, of global health. How is it, if it's not WHO, who? And are we going to move to a world where we're going to see investment that is not disease-focused or issue-focused and more health system? I hope. That's where I would like to see it. But I'm kind of still a little skeptical because I think actually the window of opportunity for seeing massive investment in health system is very small. I think unless we start demonstrating and saying that if you invest in human resources for health, this is how fast you're going to get to family planning uptake, or this is how fast you're going to reduce HIV/AIDS mortality. That is the pressing issue. That's the urgency. That is why it is such a big question. But so I think in the end, it's going to be the regions, it's going to be the countries, and it's going to be a decentralized, naturally decentralized kind of a leadership and governance that we're going to see in the future.
So there are several, I'm looking at the tweets that I'm getting emailed, and I have a question that I think will combine some of these issues, which are all about, many are about specific diseases, some are about systems, some are about funding, there's something you were talking about as well. We've taught our students for years, we talk about vertical versus horizontal interventions, right? Your report introduced something else, and that was the idea of the diagonal as a way to really approach both. Would you like to talk about that a little bit and how that could possibly resolve some of these issues and explain to the audience what the diagonal approach is?
Yeah, so we absolutely do support the notion of a diagonal approach. That is building systems with very specific health outcomes in mind, not building systems for the sake of building systems just because systems are nice, but building them in a way that achieves health outcomes. There are, again, a multitude of ways to get there. One way that we mention in our report, and I mentioned earlier, is that funding interventions should be accompanied every time by structural investment so that over time you're coalescing into a system. In some situations, in some countries, they've built great delivery systems for HIV/AIDS. That might be a natural starting point to build upon. You can almost leapfrog using that platform. I would say that the primary health care setting, the clinic, as a platform supported either side by the community on one side and hospitals on the other. That's how many countries are thinking about strengthening health systems and strengthening delivery with the clinic at its heart. But again, there's sort of no one size fits all. Just to go back to the last point on the WHO, occasionally we hear the words WHO and then people kind of groan and they're like, oh no, the WHO. We call absolutely for a strengthened WHO, a fully funded one. We as a community in some ways have let the WHO wither on the vine financially. Its flu budget, I mean, this is the thing that probably we should really all be terrified of. We should be lying awake at night, unable to sleep, worrying about the next flu pandemic, which really could kill us all. WHO's flu budget is $7 million. That's less than what New York City spends on its public health preparedness. We've got to start to get serious. If we think there are true cross-border threats, and if we think there are true global public goods, which I do believe there are, we still need we need an agency that we can trust, that produces that produces trustworthy guidelines, norms, standards, technical assistance. And so we need to start being serious about that. And that's true for other global health institutions as well. As they move away from direct country support, there is going to need to be an alignment of these institutions to support the kind of global public goods that we've been talking about.
I was informed that I can take one more question, and I'm going to... Okay, I'll take it from you. Please, yes, go ahead. And then I'll ask mine. I'm going to take the last question. Please. No, come on. No, there's pressure now. Come on. Yeah.
I know there's pressure. Literally, my past 3 questions have been taken. This is a continuation of what you've been talking about and probably follow up on Dr. Merson's question. So you were talking about buy-in from programs, and I'm hearing that your one vision is seeing more funding directed to health systems than diseases. And then one criticism you brought up in your talk was that the MDGs are really disease-focused, and that could be a shortcoming there. So as a former minister from Nigeria, as an example, and obviously anyone can speak on this, but what would you see as appealing about this model and this new sort of goal in terms of the timeline of 2035? What's different about this than the MDG ideas? Like, what would inspire that buy-in from you?
I think the focus on health outcomes and the outcomes that matter in terms of discrete investments that can yield improvement in health outcomes, I think is very appealing. That progress is possible on the infectious diseases, reproductive, maternal, newborn, and child health, knowing that there is a menu of specific interventions that, if delivered, can deliver the dividends that we want to see in the health of the population. But at the same time, I think the issue of going to scale with those comes in, because the health system traditionally, within the context of our national health systems, you get to the health outpost as the most peripheral unit. But there's life that goes way beyond that, and that's the space within which people actually live. And how do you deliver? And that's where the interface between technology, entrepreneurship, and innovation will have to come in to actually catalyze the delivery at that last mile so that people get these interventions and deliver the outcomes. I think that's sort of one. The prospect for huge fiscal infusions of resources to protect households from financial risks, I think is appealing, but in the context of a federal state like Nigeria, I think that's a bit, it will come later. It's not something that I see us making very rapid progress. At the end of it all, I think the diagonal approach is what one would like to see. Mm-hmm. And the HIV, TB, malaria, the verticals are there. Right. We're trying to move also to take advantage of those, to invest in community health workers and midwives, in primary health care centers and rural area logistics and supply chain systems, while improving those outcomes that are related to the infectious diseases as well.
Thanks. Yes, please.
You know, one example that was mentioned, but I think actually deserves closer look, is actually Iran and dramatic gains that they made, and they did it with these integrated healthcare systems in these individual villages. And looking at that example of why was that successful, I think is really there. I also want to just briefly answer Mike's question, because I think it's really good. I think ultimately the leadership has to come from the people in the countries, and you get that through transparency, and through transparency empowering individuals to put pressure. I don't have a lot of faith in multilateral international institutions. I think for things like standards and best practices, I think they can work. But we can look at the environment and climate space for two examples. So why has the IPCC and the international climate negotiations failed, but the Montreal Protocol worked? And figuring out what makes those things successful. National governments may not be the right forum if they're not responsive to their citizens. And in fact, we're seeing with more than 50% of citizens in cities, how can cities actually be the appropriate point for thinking about this thing? And then there's just another point. 20 years ago, 30 years ago, 90% of development assistance and financial flows to developing countries came from major donors. That's now 10%, right? And we're seeing new emerging groups, things like remittances, things like the Gates Foundation and a number of other foundations actually playing that role. So maybe the leadership doesn't come from national governments or international institutions, and it may even come from the private sector. Places like Nike are fundamentally, which are responsible for 50% of footwear manufacturing in Asia, in their factories, are thinking about how do we change the factories to actually make them healthier, safer, more energy efficient, better use of water. And that, at the end of the day, could have far more of an impact than USAID could. And we've got to think about these different actors in terms of what we're trying to do. Sorry.
Good, thanks. So thinking about what you just said, about how ultimately it will have to be countries, people in the countries, and industry that really helps with implementation. My question for you is, tomorrow you get a call from the G8, right? Yeah, I'm excited already.
That would be great.
Yes, right? G8 invites you.
Yeah.
Give your presentation. They're like, what? G7. Oh, you're right. It's G7. Oh, whoops. Yeah. You're right. Yeah. Gets in. Says, we're on board. Here's a lot of money. What the next 3 steps you're going to take? That's controlling for you've already opened the champagne, right? Post-champagne, what steps are you going to take?
I mean, in terms of what we are suggesting or what we are proposing in terms of international collective action, I mean, perhaps I'm repeating myself. We are calling for a much more serious investment in R&D, in implementation science, in the institutions, the global health institutions themselves and their capacity to deliver on those. We are actually hoping to brief the country that is chairing the G8 later this year, so maybe we can make it a reality. Our first real way of answering that is a project that we've just about to embark on for the Swedish Ministry of Foreign Affairs, who have asked us to examine their foreign assistance and see how it would need to be reoriented in the light of our recommendations. And I'm sure what I've just mentioned is going to be at the heart. But there are lots of unanswered questions. If we are talking about a world where countries are going to so-called graduate away from direct country support as they get richer, what does that look like, and what are the rules, and when would that be safe, and what are the sort of graduation cut-offs? There's a lot of work that needs to be done around that. We certainly are never suggesting any sudden stopping of international assistance. That's dangerous. It can lead to malaria resurgence. If there are people on antiretrovirals controlling their HIV/AIDS, you obviously can't suddenly stop funding. So there are questions ahead around how you transition, for sure.
Yes, indeed. So many challenges ahead, but quite provocative and thoughtful report already being assigned in many of our classes.
There will be a test.
Yes, I would. We will now need to conclude this portion of the event. I would like to thank Gavin and our fine panelists for a stimulating conversation. A reception follows so that the conversation can now continue in another venue. Thank you all for attending.